As we've heard, there are lots of things to complain about with regard to our medical liability system. It doesn't compensate very many people who are eligible. It costs a lot in overhead expenses. It doesn't seem to deter unsafe care. But what physicians and insurance companies grumble about aren't any of these things. It's simply that the cost of lawsuits and indemnity payments, the payments that plaintiffs get in these lawsuits, are too high and need to come down. Moreover, they complain there are too many frivolous lawsuits in the system and we've got to weed those out. So policymakers' attention has been focused on a pretty narrow goal, which is reducing the cost of the medical liability system to the healthcare industry and its insurers. They pursued that goal through a relatively narrow set of traditional tort reforms. And in this part of the lecture, we're going to examine what we know about how well those reforms work as an entree to thinking about some new approaches. The suite of traditional reforms aims at three goals. Number one, make it harder for people to get into court in the first place. For example, you could impose shorter statutes of limitation or repose, which is the time that you have as a patient between the time you figured out you got hurt and the time you bring a claim. We could adopt pretrial screening panels, as about half the states have done, a panel of experts who would hear evidence in a claim at a very early stage and decide, does it have enough merit to go forward in the process? Or we could adopt some kind of requirement for a certificate of merit. Have your expert witness give you an affidavit right up front saying there's cause to bring this claim, it's not frivolous. A second kind of reform aims to modify the rules about who pays in a malpractice suit. At common law, or historically, the rule has been that if a doctor and a healthcare organization like a hospital were both involved in a case and they're both negligent in a case, they both are on the hook for the entire amount of the damages award. Sometimes hospitals or doctors have objected, hey, this is unfair. If I was only 10% responsible, shouldn't I only have to pay for 10% of the damages? And a lot of state legislatures have agreed. About half of them have modified that rule to keep each party responsible only for its share of fault, as the jury has determined. Finally, a third suite of reforms aims at modifying the rules about how much money you can take as a plaintiff in this system. The most popular reform by far is the cap on non-economic damages, which limit the amount that a plaintiff can take as pain and suffering. A few other states even cap total damages, or the total amount that a plaintiff can take, including compensation for their out-of-pocket expenses, economic losses. A second reform, also very popular with physicians, is to cap the amount that attorneys can get paid for bringing malpractice claims, on the theory that they have financial incentives to bring a lot of non-meritorious claims. Another kind of reform, called a collateral source offset, addresses a funny quirk of this area of law that has allowed plaintiffs historically to take money from a doctor or a hospital in a malpractice case, even if they've already been compensated for part of their losses by their own insurance company. For example, if they've had medical expenses due to the injury that their health insurer has paid, they can still get paid by the doctor or hospital if there's a finding of negligence. Collateral source offsets fix that rule. Finally, there are periodic payment rules. This gives the defendants in a malpractice claim a long period of time to pay out a damages award instead of requiring them to pay right up front. Kind of like if you win the lottery, you can choose to take a lump sum payment or a periodic payment over time. This is really financially advantageous for defendants because they can get annuities and other financing mechanisms in place that help them smooth the expenses associated with the big judgment. So here are the traditional tools of malpractice reform. How well do they work? Well, before we answer that question, we should answer the question of how do we know if they're working? There are a few different metrics we might want to look at. Certainly the most important ones to policymakers are these. They have to do with the volume and cost of malpractice claims themselves. Do they tamp down the number of lawsuits that are brought and the average amount that people get paid when they recover in these lawsuits, the overhead costs of the system, and ultimately, and most importantly, do they reduce the amount that physicians and hospitals pay in the end for their malpractice insurance? That's most important because that's the pressure point for policymakers. That's what people complain about when they lobby for tort reforms. Hopefully, we're also interested in some other measures, and that is, how do these tort reforms affect the care that patients receive in our system? For example, are they helpful in getting rid of wasteful defensive medicine? Do they help states attract and retain qualified physicians by offering a safe environment to practice in? And ultimately, do they redound to the benefit of high-quality care, or do they ultimately end up detracting from high-quality care? The hypothesis there being, if you think the tort system is sending good deterrent signals, if you insulate doctors from liability, maybe they don't get those signals for safer care. So what do we know about these outcomes? These malpractice reforms have been extensively studied over the last 30 years. It's probably one of the best studied areas of our civil liability system. So we know quite a lot about some of these outcomes. And the bottom line is it's not very encouraging. So if we look first at those liability measures, what you're seeing in this chart here in yellow are the reforms that have had an effect that's statistically significant on one or more of these outcomes. And specifically what you're seeing here in brackets is the quality of the evidence base that we have. And with the zeros or the arrows, the direction of the effect that we see. So for example, we've seen evidence that pretrial screening panels significantly increase, yes, increase overhead costs. It's not a lot of evidence, it's a low quality evidence base, but not encouraging. They have the opposite effect of what we'd expect. The only thing that seems helpful here is limiting the amount of time that a plaintiff has to bring a claim, which is associated with lower malpractice premiums. Similarly, when we look at the effects of these same reforms on our care metrics, there's a lot of zeros in this grid. The only statistically significant effect that we see here has to do with pretrial screening panels. They seem to modestly decrease defensive medicine. The one reform that's really an exception to the general rule of no effect here is damages caps. This is the one reform that pretty consistently seems to affect the outcomes that people care about. But note a couple of things here. One is that overhead costs seem to go up on average when you have damages caps. Now, why is that? Probably because when damages are capped, plaintiffs' attorneys make more careful choices about what kind of case to bring. You might, on average, get more complex, expensive cases being brought, and that would make it more complex to litigate them and bring up the overhead costs of the systems. But what matters here to doctors and physicians in this grid is that arrow showing that non-economic damages caps can bring down malpractice premiums. That's a great finding, right? Until you realize the magnitude of the effect. States that have these caps in place will see their malpractice premiums grow on average about 6 to 13% more slowly than states that don't. It's not by any means a panacea to the problem here. It's helpful in a statistically significant way, but perhaps not in an economically meaningful way. When you look at the effects of these traditional reforms on care-related measures, again, you see the only thing that's lighting up the board here are damages caps, and they're helpful. And here the evidence base is actually pretty strong here that they're helpful. But again, the magnitude of the effect is not huge. For defensive medicine, we're talking about an order of magnitude around 5% lower growth of spending on healthcare expenses in states that have damages caps. So, in summary, most of these reforms do nothing, as far as we know. Those that do something do only a little something. So I think it's important to think about what we're buying for all of the policy energy that has gone in to trying to get these reforms passed. And it has been an enormous amount of energy. The battles over these reforms have been epic, and they don't stop once they're adopted. These reforms, particularly damages caps, get challenged in court. They get litigated for years. There are lingering uncertainties around whether they're going to stick. In some states, you see them being passed and repealed and overturned and passed again. So an enormous amount of energy put into these things. And as the evidence base has accrued that they have modest effects, really the amount of enthusiasm in the policy circles has weakened only modestly. There continues to be high levels of interest in these reforms and in repealing them in the states that have them. So from a scholar's perspective, it's disappointing to see so much attention focused on things that we know with a pretty good level of certainty don't work, or if they do work, the juice doesn't seem worth the squeeze. So what are the alternatives? Let's talk now about some of the newer ideas on the table for reforming the malpractice system.